Hello, my name is Dr. Andrew Morgan. I'm one of the Divisional Medical Directors at RWT. In this video we're going to talk about patient flow and a tool that we've developed to try and identify where we can help patients progress through their hospital journey. To keep our patients safe, we need to ensure that we have patient flow throughout the organisation. If there are blocks in the system, such as the exit from ED and discharges from wards, this can cause harm to patients. It is well documented that patients that are stranded in an overcrowded emergency department have a higher rate of mortality, and patients that are delayed in discharge from wards are at risk of deconditioning and are exposed to increased risk of problems such as hospital-acquired infections. In order to prevent unsafe backlogs of people who are ready to be discharged, we need to identify what the blockers or constraints are in the system and try and fix them. Some of those issues that affect patient flow are external, but there are also a large number of internal constraints. We can affect these issues if we know what they are and help with patient flow. In this video, we will look at the Huddle data collection tool. This is a computer program which has been developed by the Trust, and this records the constraints so that we can better focus our improvement efforts. Aside from this, the tool records useful information on frailty and end-of-life assessments, which can inform care both for inpatients and patients in the community.
Hello, my name is Elaine Bolus and I'm a patient flow assistant in the Trust. We use the Huddle tool to record the details of what's happened at the ward huddle each morning, so everyone has a clear idea of the task that required that day. The tool's so easy to use and provides reports at the end of the huddle which we can use on the ward, and it will also be used to report delays centrally to the capacity team. VJ, who designed the system, is now going to talk us through how to add actions onto the system and generate these reports.
When the system opens up, we're presented with this interface. As you can see, there are several modes in the system. However, today we will focus on the ward and dashboard modes. The interface may look complicated, however, most of the information in this system is pre-populated when we select a patient. The system presents a user with key information from other systems around the Trust, which can highlight potential delays for a patient's care. For example, the system displays D2A and teletracking delays. To start entering data in the inpatient huddle, a user selects a ward and a list of all current inpatients are displayed. In the inpatient huddle, patients will be discussed one by one, and once a patient is selected and discussed, the following information will be captured. Red or green day, this is defaulted to red as per NHS guidance. Delay reason, for example, is it a medical or social reason? And finally, the action that is needed to progress a patient's care, and also the person who will be assigned to that action is recorded. Once all patients in the huddle are discussed and data has been captured, an action report is then generated which displays what has been discussed and what actions are required. The ward can then use and monitor this action report to ensure actions are carried out. As you can see, the tool also has the capacity to record clinical information such as end-of-life assessment and frailty assessment. We're now going to hear a little bit more about the frailty assessment.
Hello, I'm Dr. Mark Whitsey. I'm one of the consultant geriatricians here at RWT. The Huddle tool allows clinicians to score frailty for their patients. Well, why is this important? Well, frailty is commonly defined and understood to be accumulation of deficits in physiological systems that result in a patient potentially having worse outcomes from any sort of stressor, no matter how insignificant we might think it is. This may be better described as this picture shows. In England, an estimated 1.8 million people over 60 and 0.8 million people over the age of 80 live with frailty. It's important to remember that frailty is distinct from living with one or more long-term conditions or disabilities, though there may be overlaps in their management. Age, whilst correlated with frailty, is also distinct. older people living with frailty can be low users of health services until a relatively minor event precedes a major change in their level of need. In the Trust, we use the Clinical Frailty Scale score, also sometimes called the Rockwood score. This is a simple 1 to 9 score, 1 being a very fit patient to 9 being a patient who is terminally ill. This pictorial scale is available on the Huddle tool to support you. The score should be a comprehensive assessment based on how the patient is 2 weeks prior to admission, not what they are like functionally during an acute illness. We would advocate completing the score after all members of the MDT have reviewed the patient, probably on the second day of their admission. It's important that we recognise and identify people and patients as being frail during their acute admission, as this can allow us to plan and optimise a patient's care to avoid further delays down the line. Here is a document that can help support this, which is also available on the Huddle tool.
Thanks, Mark. As Andy said earlier in the video, if we have blocks in our system, these can stop patients leaving the hospital. This can cause delays for patients when accessing inpatient care when they need it. To have the biggest impact on patient flow, we need to tackle the biggest issues that delay patient pathways. When actions are recorded in the tool, it records any delay reasons so we can diagnose the issues in the system. If you press this button, the tool brings up a report detailing the constraints in your area. If you look on the right-hand side of this report, you can see that the report highlights the issues that have the largest effect on patient flow. If as a team you undertake improvement efforts against these issues, you can use the left-hand side of the report to see the difference in key flow metrics, namely weekly discharges, number of long length of stay patients on your ward, average length of stay, and readmission rates. If you would like more information on the tool or need help with continuous improvement projects to help with flow, please contact the CQI team on our email address rwh-tr.cqi@nhs.net or on our Twitter @rwt_CQI.